Okay, good afternoon. Thank you for joining us today. My name is Sarah Stoddard. I'm an associate professor here at the university and the co-director of the Training and Education Core for the Injury Prevention Center. We're excited to have you join us today for this event. I have a few announcements before we get started. The University of Michigan Injury Prevention Center is one of 9 CDC-funded injury control research centers nationally that address urgent injury issues with research, education, and outreach. We cover many topics, but we have more of a particular focus on opioids and overdose, suicide, violence, concussion, motor vehicle crash, older adult falls, global injury prevention, ACEs, and other emerging areas. So really, we cover pretty much the spectrum almost of injury. We have many members, and it's easy to become a member of the center. To become a member, go onto our website, and through membership with the center, you receive announcements, so like the event today, and other opportunities both around training and around other activities through the center. We have some upcoming events. There will be on November 3rd from 2 to 3, we will have a it's in the afternoon, but kind of a lunch and learn seminar where our students that completed summer internships with us last year will talk about their experiences. And it's really geared for students who might be interested in completing a summer internship with us this coming year. This will take place at the School of Public Health, and there's more information on our website. As I mentioned, we also have summer internships. The call for applications for that is out. We typically have about 5 internships per year, and these kind of range from being in kind of research entities within kind of the Injury Prevention Center, but also some of them are in collaboration with our community partners. And again, there's information available if you're interested in applying for a summer internship. And then last, we have a summit that's going to take place on February 15th. It's Learning Without Violence, a School Violence Prevention Virtual Summit. And there is currently a call for abstracts out if you're interested in presenting. They are due November 11th. And again, more information on our website. So now I'd really like to introduce our speaker for today. Dr. Elizabeth D'Amico is a senior behavioral scientist at the RAND Corporation and a licensed clinical psychologist. She's recognized for her work developing, implementing, and evaluating interventions for adolescents and young adults across a variety of settings, including middle schools, primary care, homeless shelters, and teen court. She has grants focused on prevention for substance use for urban Native American adolescents and young adults that integrate motivational interviewing with traditional practices such as beading and Native American cooking. She is currently conducting a large clinical trial to address suicide prevention among Alaska Native youth in Alaska. She has also conducted epidemiological work to examine predictors and consequences of adolescent substance use and is the principal investigator of a longitudinal study examining substance use patterns for over 18 years among youth from 6th grade through now age 28. Please join me in welcoming Dr. D'Amico.
Thanks so much, everyone. Oh, let me turn on my mic. So thank you for coming here today. I'm really happy. Can you guys hear? There. All right, cool. So don't turn my head too much. I'm excited to be here. It's a real honor to come here and really thank Dr. Walton for having me. It's been super fun seeing the university and meeting many of you today. So I look forward to talking with those of you who are here. If you're not here, you're missing out on some really good meatballs. So sorry about that. But hello on Zoom, whoever's on there. I'm going to talk to you today about some of the work I've been doing in the community over the last 20 years. And then I know there's going to be time for questions at the end. So I'm looking forward to hearing from all of you. I got to turn this the right way. See, as soon as Jill left. Yeah. You know what it is it's on the, I think I know what it might be. Okay. There, it wasn't, it was on the other thing. I figured it out from before. I feel so talented. Anyway, so I'm going to talk a little bit about adolescent and emerging adult alcohol and other drug use, kind of give you a sense of what it looks like. Talk about some of our work in understanding disparities, some of the interventions I've done targeting diverse young people. And I think what's a really important part of my talk, and I know I've spoken with a lot of you about it today, is thinking outside the office. It's really important that we create things that are sustainable and feasible in these communities. And that relates to really bridging the gap between research and practice. So here's some data kind of looking at alcohol and other drug use during the teen years. Now there's some highlights here. I know you all know this, it increases. Wow, surprise. But what's important to note is when the increases happen, right? So, and if we had sixth grade on here, we'd also see from sixth to eighth grade, a 30% increase in use, right? So this is why we want to target middle school. This is why we want to target high school. And despite what we often hear, it's still alcohol and pot. And you'll notice vaping has caught up. Particularly, I think we've had, somebody was mentioning, oh, California does so good with tobacco. Well, not so much with vaping. In the last couple of years, we've finally seen increases in combustible cigarettes after this huge downtrend. So it's really becoming an issue among young people. So as we go into emerging adulthood, we're going to see similar things. Now, you would expect with lifetime use, right? There's some people that might just try it once. This doesn't mean they're using regularly. But again, I think it's just important to note that alcohol is the highest on here. And we do see pot with about 44%. And I know I bring up the cannabis a lot because I know we're dealing with a lot of issues around that in California and other states because young people really don't see the harm in cannabis that they do with alcohol. So a lot of teens will say, I would never drink and drive, but I use weed and drive because it helps me focus. So that's what we hear. And we got to talk to the teens about that because we know it's not good to do that. So a big part of the work we do also is not only understanding use, but we have to understand some of the disparities that happen in use. As many of you know who work with historically marginalized populations, we often see in these populations that even when they use at similar levels, they experience greater consequences. And so we really tried to address this in our data, really trying to understand when do those disparities first happen? Because we know they happen in adulthood. And our team was one of the first people to really show that these start happening in high school. And so we have used this choice cohort, which started out in 16 schools with about 15,000 students when we were doing an intervention study that I'll talk to you about in a bit. And we continue to follow a cohort from age 11, about 2,500 teens that are now 25, to look at their patterns. And you can imagine, think of all the things that have changed just in the last 10 years. The vaping, cannabis, right? So we're able to capture a lot of these changing patterns and evaluate use over time. So this cohort started in 2008 and they started around age 11 and 12 and we're able to currently survey them until age 26. And if you look at these years, again, you can see the many things that have happened in terms of changes in substances. So what's cool about our survey is we try to make it developmentally appropriate. So every year we change the survey and we fight over the questions that we get to put on because we can't make it 500 questions, right? And what questions we're going to take off. And so we've really been trying to focus a lot more on functioning. We're focusing more on transitions, emerging adult roles, education, employment, things like that to understand substance use patterns and their effects. So some of the work that we've tried to do is look at these trajectories over time and try to understand for specific populations what happens. And so recently with Dr. Dunbar, who got a sexual gender minority supplement, we were able to not only look at racial ethnic disparities, but also look at disparities for sexual gender minority individuals. And what's really important is that we notice, as I mentioned earlier, at the same levels of use, these people experience many more consequences, whether it's legal, social, mental health, physical. Now, obviously, there's other things that are affecting this, right? Discrimination, minority stress. And so I think this is really important for us as practitioners and providers to understand when we're developing our interventions. that people are having these disparities at an early age, and we need to begin addressing them. So probably some of you are wondering, why the heck do I care about adolescents, or how did I even get into this? It's true, it started with the convertible yellow Mustang. One day when I got my driver's license at 16, and you're probably like, oh, you poor spoiled kid, but I got a crappy red car. Fine, I had a car, I'm spoiled, okay, fine. But to me as a teenager, it was a crappy red car. And one day as I was driving home, I saw this beautiful yellow convertible Mustang and thought, I should really be driving that, not my crappy red car. So I got home that day and I said to my mom and dad, I'd really like to drive this convertible yellow Mustang. I said, I'd really like to trade my car in for that. And they were like, well, okay, why don't we talk about it after dinner? They didn't laugh at me. They didn't make fun of me, right? They were like, okay, we'll have a chat about this. So after dinner, I proceeded to lay out my plan of all the reasons why I should have this car. And they listened. And I'd like to tell you that they got it for me, but they didn't. But the point being is that they really listened to me. They listened to me even though they said no, right? And as I look back, I think about as adolescents, how we're always getting told what to do, right? Go clean your room, do this, do that, you can't do this. And how listening to people can be so empowering. And this really led me on my journey to think about how can we listen to teens and emerging adults and all people to help them really think about the choices they're making, which led me to motivational interviewing, becoming a motivational interviewing network trainer, and really incorporating motivational interviewing into all of my interventions. So, if my mom and dad were on Zoom, thank you, mom and dad. It's being recorded, so we'll make them listen to that part. So as we're thinking about working with this age group and young people, there's some key policy questions that we have to answer. First of all, how do we reach people? They're in a lot of different settings, and we need to reach, as you saw earlier, diverse young people because of these disparities. So how do we find them? Secondly, what do we do to make sure the programming is engaging, right? If we want young people to show up, it better be a little bit entertaining, right? Maybe free food like today, right? Maybe some of you showed up for the meatballs. That's awesome. So we got to think about how can we make it collaborative? How can we help people think about choices? And then how are we going to create programming that's sustainable? So when all my grant money's gone and I've worked with you as a community provider, what are you going to do when the money's gone? Are you going to still be able to do my program? And so we have to think about these things when we have grants and we're building these things for the community. So I'm sure many of you know there's a lot of factors that influence whether or not young people are going to use. Peer approval, super important, right? You all probably remember being in middle school, or I don't know if you've been on a middle school campus recently, right? It's pretty entertaining. I see some people smiling. It's an adventure out there, right? And peer approval is super important during this period. Whether your best friend uses is also really matters. And we also know that an important adults that use in your life can have an impact on whether or not you use. Siblings, super important. I like to think that. I'm an older sibling. I know I influenced my brother. So siblings, a peer and a family member, and also advertising. And this is a big issue as we've seen recently, and I don't know in Michigan what the rules are around advertising, but we had in California, there was no regulations around advertising when weed was first legalized recreationally, which created a lot of issues. And we were able to measure this with our study and showed that even before it became legalized over the 7 years, advertising increased, and it was related to increased use of pot among teenagers. And they were able to use this data in LA County to create an ordinance so that you couldn't advertise in certain areas like in front of schools or playgrounds. And so it's important that we have this data so we can tell policymakers and providers changes we need to make, right? And that we're still one of the few states, I think, that can advertise on billboards. And I don't know, well, I've seen billboards here. So you guys have the billboard thing, yeah. The cookie billboard, that's right. Yes. Well, and they even have rules, and not in California, but there's this superhero guy called Mr. Superhero Cushy Punch, and it's all written in like bubble letters, and you can't do that like in Washington or Colorado. You can't have certain fonts or letters. We don't have those rules in California. So it's just something to think about, who they're targeting, what young people are seeing. So I'm not going to talk to you about all these interventions, but I did want to highlight some of them for you briefly, just to give you a little taste of all the different settings that we've worked in. So Choice, as I mentioned, is a middle school intervention we developed, and it was after school, and it cycled throughout the year. So we had a session every week at the schools. Chat, I'll be talking with you a bit about, is a primary care intervention that we did for 14 to 18-year-olds. And that was a 15-minute brief intervention, part of the doctor appointment. Makune, which is motivational interviewing and culture for urban Native American youth, is something I developed with Dr. Dan Dickerson, who's an Alaska Native addiction psychiatrist at UCLA. And his focus is really on integrating traditional healing into evidence-based practices. So using drumming, for example, to address substance use disorders. Project Aware is something I developed with Dr. Joan Tucker, who does a lot of work with young adults experiencing homelessness. It's a motivational interviewing intervention. It's 4 sessions that take place in drop-in shelters. And we focus not only on substance use, but also on risky sexual behavior. Interestingly, the youth, when we were testing this out, we always spend about a year in every grant figuring this out, said, do not talk to us about cannabis at all. We don't think of it as a drug. We don't care about it. So we didn't put it into our program at all. We focused on alcohol and other drug use. But in every session, cannabis use came up. And we ended up actually reducing cannabis use and motivation to use, even though we didn't directly address it in the intervention. So just listening to them and not saying, cannabis, can do, they didn't want to know that. And so I think that's another important thing when we're creating these programs, is to really understand who you're going to be working with and the things that they want to know and hear about, and how you can create a program that still maybe addresses it, but in a way that fits for that community. Free Talk is an intervention we developed for teen court, and these are for at-risk youth who had a first-time alcohol or drug offense. So you can imagine they were super happy to have to get 6 sessions of, whatever. And then they got 6 sessions of our motivational interviewing program, and we did a trial around that. And then finally, as part of the funding that also Dr. Walton has, the Night of Heal, helping end addiction long-term, is Takuna, which is Traditions and Connections for Urban Native Americans. And it focuses on opioid misuse and also alcohol and cannabis use. So these are some of the projects that I've worked on, and I was going to talk a little bit about each one, well, not each one, a couple of them in detail. So I think one of my favorite programs is one of the first ones we developed, Choice. And this was a voluntary after-school program, and it had 5 30-minute sessions that focused on norms, right? Not everybody's doing it, because if you ask teens, how many do you think are using weed? They're like 100%, 100%. And so showing them the data that that's not true can be really helpful. We also talked about how to cope with feelings and prepare for risky situations. And the sessions just cycled over the school year, 1, 2, 3, 4, 5, 1, 2, 3, 4, 5. So they could just show up whenever. And we had free pizza and juice, so it's like I came for the pizza, not because I had a question about drugs. And we obviously didn't put the room where we held it next to the principal's office, right? We did it in the cool teacher's room after school. So these are all things to think about to get people to come. So this was done in 16 schools, and 8 of the schools got the program. And so what you can see between the control and intervention schools is that they were pretty similar, and it was a very diverse population. Most of the schools that we were in LA were Hispanic or white or Asian. So we didn't have as many Black students in the schools that we happened to be in those districts. Although you can see we did get about 4% Blacks. So what did we find? Well, we did Choice over a year, and what we found was that the teens that came to the program decreased their alcohol initiation, and they increased their ability to say, no, I don't want to do that, or find ways. Now, what's also really cool is that the 8 schools that got the intervention, the entire school population actually also decreased their rates of alcohol initiation because we surveyed the entire school. And we were like, wow, that's super cool. How did that happen? Well, positive peer influence. Teens talk to each other. So teens who went to Choice told other teens about the program and said, hey, guess what? Not everybody's using. Guess what? Here's some strategies you can use to say no. And what's funny is we did a survey where we asked the teens who came to Choice, what did you tell people about the program? And then we asked the teens who didn't come, what did you hear? And in all my life, this has never happened, but it completely mapped onto each other, where they said, we told them not everybody's using. And the teen said, they told me not everybody's using. So it was really cool, this social message spread. And when we did a cost analysis, it ended up costing about $20 a student, all in all, to get decreased initiation. So remember, 6th to 8th grade, that's when we see a 30% increase in initiation. Being able to decrease that is huge because we know if you initiate before age 14, you're 4 times as likely to have a substance use disorder. So if we can even delay it a little bit, we can have a really big impact. Chat is an intervention we developed in a pilot trial, and then we tested it in 4 primary care settings. And part of this was testing different screeners for NIAAA. So youth that screened into this, when they screened in at risk, they either reported they were drinking or that their friend was drinking. Now, what's interesting about this is even though they screened in for alcohol use, and this was before legalization of pot, this was in Pennsylvania and California, the majority of teens were also regularly using marijuana already. So I know those of you in this field know this, but I want to highlight, I mean, this was back in, gosh, when was this? The early, maybe like 2012. So what we did was half the teens got this brief 15-minute intervention, and then half of them got a brochure that talked about substance use, because as you know, we don't always know what happens in primary care. We hope that teens get screened. We hope they get asked about substance use, but maybe they don't. So this way we made sure everybody got something. So you can see from the sample overall that the average age was around 16, okay? It was more female, which you tend to find in primary care, and it was pretty diverse also in terms of Black, Hispanic, and multiracial. Now, one thing I want you to look at is the prevalence, okay? What I think is fascinating is that heavy alcohol use for the whole sample is at around 22%. Heavy marijuana use is 19%, which means using more than once a day. So already we're seeing the rates of heavy use are pretty similar. But what you will notice in terms of DSM-5 diagnosis, which was with the CSED, or what is that thing called? The CES-D, you know what I'm talking about, that thing. Anyway, so 4 times the rate of cannabis use disorder versus alcohol use disorder. So again, I think this is important because I think a lot of people still tend to see less harm with cannabis use. We also see in our other work with that longitudinal cohort that teens and emerging adults who report regularly using marijuana report more consequences in physical health, mental health. I'm not saying alcohol use doesn't have problems too, but I think as providers, practitioners, communities, we need to understand that cannabis also can have a lot of consequences for this age group. So what we found 1 year later was that the teens who got our chat intervention reported decreased alcohol use and consequences, decreased marijuana use and consequences. They had more accurate norms, which is good, and they changed their social context. They stopped hanging out with a lot of teens who used. So again, a very cost-effective intervention, 15 minutes to have effects 1 year later. And I can tell you from listening to the tapes, it was fascinating to me because these teens would come in who would be like, yeah, I use pot every day. And by the end of the 15 minutes using MI and getting them to think, they'd be like, maybe I might want to cut back. Like it was incredible. And so I think, you know, we can reach people in a short time frame, which I think is really important. Another one of my favorite interventions is Makune, which is motivational interviewing and culture for urban Native American youth. And this, as I mentioned earlier, was developed with Dr. Dan Dickerson, who's PI with me on this project. Those of you that have worked with historically marginalized communities know it can be really difficult to do randomized controlled trials, which is quote unquote this gold standard, right, that we have to have. And this is what we're supposed to be doing. And if we don't do an RCT, then, you know, who's going to read the paper? And so we worked for a year with the community. We also have an elder advisory board that we work with to really understand how could we do a randomized controlled trial that would be okay in these communities where people could learn from it and also feel like it was okay to participate. And so based on all of those discussions, we did not have a control group. So in this study, everybody got a cultural experience, and some people just had more than others. And then at the end of the study, everyone who didn't get the 3 workshops that I'll show you in a minute, we went back and gave them to them. And so I think, again, that's another important thing as we think about writing grants and doing things in the communities, is we have to provide funds in there because nobody wants to be in the control group. And so even with choice, the 16 schools, we gave 8 of the schools the program in year 1. We did our evaluation, and the other 8 got choice at the end. So everybody got it. And I think that's really important when we're doing this kind of work. So what everybody got was what we called a wellness gathering, which was this 2-hour event we planned monthly across the state of California, depending where we were, where we had an elder come. And it was an event with dinner, so the entire community could come in addition to our participants, and they would do beading or storytelling, dancing, drumming. We had an HBO Native American comedian come. We had a lot of different people come and present, and they would talk about the importance of culture, and then also discussion of making healthy choices. And then families would get together and you could connect with other people in your community. Then half of the teens also got these workshops that we created. And there were 3 workshops that were 2 hours long. And you're probably going, oh my God, how did you even keep teens for 2 hours? Well, I was not a fan of this. Originally, we had 6 sessions that were 1 hour. And then the community was like, there's no way with transportation that we're going to be able to come. You're going to have to redo this. So we redid it. And then we started thinking about it, Dan and I, and we were like, you know, it is 2 hours, but the first hour is kind of chatting and interactive about substance use. And the second hour, you're doing a prayer ceremony, you're cooking, you're beading. So it's very different. So it wasn't like you're sitting there for 2 hours, you know, doing the same thing. And it ended up actually being okay. And the teens really liked it. And the other thing we had to do is we didn't want to say, oh, here's a little bit about substance use and here's some culture. We had to really integrate the 2 things together. So the way that we did that and talking with the community was really thinking about how can you connect substance use with resilient protective factors and show how culture can be protected. So in workshop 1, we focused on beading because I don't know if anyone has ever beaded, but it is hard. And so we wanted the teens to have the full 2 hours to complete their project. So in LA, they did a medicine bag. So it began with beading, and then what the cultural, you know, it depended on the cultural teacher. So in different areas, they beaded different things. And then the second half focused on how substances can affect your brain. And it really tied in well with the beading because you have to really concentrate. You know, you mess up your bead work, you have to pull out and start over. And so it was really highlighted like how the culture, right, can be protective. And these are important things for your brain and how substance use can affect it. And then we always do fun things as part of this. So we did a memory game to try to show them how substances affect their brain and made it very interactive. Workshop 2 focused on choices around alcohol and drug use and how do people walk down this path, right? None of us use substances because we want to become addicted. And so how does that happen? How do people experiment? How do they go on to problem use? How do they go on to addiction? And how do they get off that path? And so focusing on those kinds of choices, for those of you that know MI, we did rulers, right? What's your motivation to change? How confident are you that you could change? And then we did the medicine wheel and we focused on Native cooking and healthy choices around food. As many of you know, for urban Native American people, because of many governmental policies, including forced relocation, there's a lot of health issues, right? People were forced to eat food that was not part of their Native culture. There's one tribe that when kids are born, they have diabetes because of this, 98% of the tribe. And so it's really important to try to connect teens back to their Native culture and think about food. And so this was all about choices, and it was really fun. And the facilitator would make like salmon or buffalo stew, and they would get a recipe and they would get to eat and have a meal together. And then the last workshop was really focused on thinking about your future and how do the choices you make affect your future. So we had this really cool giant wheel of the future that they could spin, and it would go on different colors. And then depending on the color, you know, it'd say, I went to a party and a really hot guy or girl flirted with me, and they wanted to take me to another party and I knew they'd been drinking. And then we would talk about what would happen if you made this choice. How would that affect your goals? And then the second half of the session was really focused on taking that a step further and thinking about your spirituality and whatever felt comfortable for you, and reviewing the medicine wheel and doing a sage ceremony with prayer. And so that's kind of how we tied all these things in together. So here's an example of the sample demographics, and you can see that we had not as many 18-year-olds as 14 to 17-year-olds, which I thought was interesting. And I'll talk about that a bit more in our next study. It's hard to get those emerging adults to come to stuff. I don't know if anyone's recruiting for those, 18 to 25, but getting them to come, you gotta have some good incentives. And we did, but not as many came. You'll also notice with this population that a lot of the Native American youth were of mixed race ethnicity. And that becomes important as you think about development and the next project I'm going to talk about, because identity is a big part of this, of every adolescent's identity, and particularly for Native American youth who have had to deal with historical trauma and other things. And so we know that identity can be protective, and that can be a way to increase resilience. And we'll talk about that in the next project. But what we found actually, this should say 6 months later, sorry, 6 months later, was we did not see differences between those two cultural groups. What we saw was that instead of increases like you normally see during this time period, it's stabilized. So people didn't end up using any more than they, like they normally would. And it highlighted for us really how important culturally centered programming is for this population, because it's not easy to access these resources. And so really providing them in these urban settings is a way to increase resilience and protective factors. And a lot more work needs to be done with this underserved population in ways that are collaborative and that fit for the community. So I've talked to you about 3 interventions, and I think an important takeaway is that we were able to reach very different young people across different settings with minimal cost and have a big impact. Choice, 15% came, effects at the school level, $20 a student. Chat, 15 minutes in the doctor's office, reduced use and consequences 1 year later from one little talk. Right? Makune, 1 2-hour cultural event, stabilization of substance use. So I think this really speaks to thinking about how we can creatively work with different populations and teens to get them to access different kinds of interventions. So this leads me to the final project I wanted to talk to you about, which is part of the NIDA Heal initiative that Dr. Walton is funded under. And this is Tikuna, which is Traditions and Connections for Urban Native Americans. And again, this is with Dr. Dickerson. And this focuses on that fun age of 18 to 25. So we tried to take some of our Makune work and use that as a base, but knowing this is a completely different developmental period, and we're going to have to think about how we want to intervene with these youth and how we want to collaborate with the community. So why do we need Tikuna? I know many of you know about the opioid epidemic, but it's particularly hit Native American communities hard, and particularly in urban areas. And a lot of work is often done with young people on rancheria or reservation, and we kind of forget about our people in urban areas. I've talked a little bit already about some of the risk factors with historical trauma. There's also this social and geographical fragmentation. Many teens may not even have access to their tribal culture, their specific tribe, depending where they live, right? So they might have access to maybe pan-Indian culture, but they might not know their own tribe's rituals or ceremonies because they just don't have the resources. And so that causes a lot of problems, and there's not a lot of opportunities for cultural involvement. And there's really no evidence-based prevention programs to address substance use among urban emerging adults in this population. So what we tried to do, and the great thing about these NIDA-funded projects is that they really wanted you to work with the communities. Oftentimes you got to just put that in, but they really wanted to see that in these. So we were able to take some time to develop the intervention content through focus groups and a pilot test. Again, it's a randomized control trial, your quote unquote gold standard, but again, we have no control group. Both groups are getting a cultural intervention. One is this culturally appropriate opioid education workshop, which is based on work that SAMHSA has done. And it talks about how the epidemic affects Native Americans and incorporates some culture and traditional practices. And then the intervention is our workshops with this wellness circle. So we did focus groups in California pre-pandemic. We were able to go throughout the state. This was originally designed to be done in California, to be done in person, and I'll talk to you about what happened. I know many of you had projects or work going on. So we did 13 focus groups with 91 people, providers, parents, emerging adults, and our elder advisory board. And they told us a lot of really important things that helped us design the workshop. So focusing on cultural identity, we heard again and again, how can you tell your story, tell your digital story? Talking about traditional practices and social networks. I feel like this, sorry. Is that better? Okay, sorry. And then also focusing on substance use. So based on that, we created this culturally centered program using the medicine wheel to focus on the behavioral, spiritual, and emotional. And we had our similar focus on traditional practices, but it was a little different. We really focus on identity more in this. We still did native cooking. And then we also did sage and prayer because people felt spirituality was very important. And then we added this social network piece because we kept hearing over and over how important connections were and how they influence behavior, and how having protective connections in urban communities can really help people make healthy choices. And so we have this whole awesome component where they do a social network survey and they get to see their pictures of who in their network uses substances, who engages in traditional practices, and maybe those overlap and they have a discussion about it and how, you know, maybe I need to change my network, maybe I don't. How can I get support if I want to make healthy choices? And when we did the pilot test, the pandemic hit. So we were supposed to do a pilot test in person that Saturday, and then everything shut down, all the organizations, everything. And Dan and I were like, okay, we're in the middle of this RCT, about to start. We're going to have to move everything to Zoom. And we were like, oh my God, how are we going to cook on Zoom? How are we going to burn sage on Zoom? How are we going to do all of this? So we started testing it out among ourselves and made Dan the chef. And we all practiced cooking on Zoom and tried all this stuff out. And we were like, okay, we think we can do this. And then we did a pilot test. And so what ended up happening is these emerging adults got this awesome box of goodies filled with stuff to cook Three Sisters stew. They got sage that was handpicked by our community partner that was packed specially for them and wrapped from Sacred Path Indigenous Wellness Center. And then they got their cool handouts. And we just mailed it all to them. And it had, you know, awesome swag in there too. Swag is always good, right? I got some swag today. I was very excited. So water bottles with Chacuna, right? T-shirts, all kinds of stuff. And so we tested the 3 workshops virtually to see what would happen. And what we found was that it went really, really well, better than we could have hoped. And the young adults really enjoyed the focus we had on culture. You can see from this quote, it really highlights, I think, what a lot of them experienced when they were going through the workshop. Is this person talks about how I lived mostly in a white dominant area. So when I was growing up, it was a lot of girls who didn't look like me. And I remember me and my friend, she'd always tell me she felt the same way, that she wanted to be like lighter skin and blonde hair, blue eyes. And looking back, I can't believe I thought that way. Like I would never think that way now. Like I love the way I look, like I accepted it just like the girl in the video did. And so I think for me, this really highlights how we have to think about development, because this age group, I feel like I'm really loud now. Should I move this down? Is that better? The adolescents in our Makune, they probably weren't ready to talk about this in this way yet, but these emerging adults were really ready for this. And so we really focused on telling your story and digital storytelling. The other thing, how those virtual traditional practices worked out. People really liked it. This person says, I loved it. I'm native, but I don't really practice. And that's why I joined this discussion. I love the cooking because I felt more connected to my native side. And what's really cool, because Dan and I listened to all the workshops, is people, we give them the base ingredients, but then they're like, oh, we add chicken when we do it my way, or someone will say, I add this spice. So they kind of start talking and exchanging recipes. And that's kind of what we want, is creating these connections. So it was really cool. They also love looking at their social networks and how it affected them. And it's very powerful to look at it in that way and see like what your network looks like, maybe who's influencing you and where you can get support. And then finally, they really felt like the substance use was so important to discuss and how it ties in with mental health and trauma and identity as being Native in different communities. So this feedback helped propel us along, where we were like, okay, we can do this virtually, we can make it happen. And so we did. And to date, we've had over 1,100 people screened in for eligibility. You can see that we've consented about 339, and you can see that some people aren't eligible. Maybe they have opioid use disorder, so they get referred to treatment. Maybe they live on a rancheria or a reservation, because we focus on urban population. And so what I can't believe when I look at this is, my God, we're already doing 12-month follow-up. My survey research group, we already have 121 people who've done their 12-month follow-up. It's just so crazy to me that this has already happened and happened so quickly. And what was crazy was how we had to recruit people, because normally we go out into the communities and do it, but we had to do this all virtually. So when we started doing this, I had an amazing assistant who looked up some metrics, and we worked with Native American graphic artists to design our ads, figure out how were we going to reach the population we wanted to reach. We put an ad out there, and within 1 week, we had 141 people signed up. And I was like, oh my God. So it was amazing. And you can see from these metrics, like how many people click on our ad, how many people it reaches, and how many people actually view the ad. So this kind of also helped us figure out which ads were better than other ads. We had to think about also one thing, and I don't know for other people who do social media recruitment, we have a lot more people who identify as female in this study than male. It's like 85% to 15%. So we're thinking, well, originally it was much lower than that. It was lower than 10. And we were like, how can we get more people that identify as male? We're talking with our elder advisory board, our community, and we brought on new recruiter and thought more about the ads. And this is Paige. So he's in our ad. So he started creating some ads for us, and he has, he's called Uncle. He's in Washington, and he does a lot of like, I guess, short videos and other things, and he's well known. And since he's been on board, we've had an increase in those who identify as male in our study. So we're at 15% now. We were at 8%, so that's pretty good, almost doubled. So again, like things you got to think about when you're doing all of this virtually, and how you can have the community help you. We also had to move all our wellness circles to virtual. In some ways, I feel like this has been better because more people can attend, and we can have people from anywhere do the wellness circle because they could do it on Zoom. So here's an example of 2. We had Charmaine Weed, who is a bareback horse rider, who just released a documentary about her life. and how she dealt with historical trauma growing up and how she channeled that into these protective factors and became a bareback rider, and how it really saved her and helped her stop using substances. Then we had Ernie LaPointe, who is the great-great-grandson of Sitting Bull, come and talk about his life and things that he's experienced. And then people in the community can ask questions and participate, talk about healthy choices. So it's really quite a cool forum. So we do this every month. So to date, we have 284. You saw a higher number on the recruitment. This is what I have the data on, because I can only make my programmer redo this so many times before he gets annoyed with me. And so you'll see we're actually getting more older emerging adults, which I thought was interesting. We're still not getting those 18-year-olds. I don't know what those 18-year-olds are doing. Most people tell us they're playing video games. So maybe we need to make a video game intervention. I don't know. If anyone wants to develop that app, let's chat after. And you'll see again that race ethnicity is also mixed, where people endorse different races and ethnicities, with Latinx being one of the main ones. Now, what else was interesting is, remember, this was only supposed to be in California. So we had to get permission from NIDA, because we said, well, if we're going virtual, why don't we just recruit across the United States? We've had people from over 25 states participate in this project. And what is so cool is I'll listen to the workshops. There'll be someone from New York, someone from California, someone from Texas, and they're all talking about similar issues they're dealing with in their areas. They can connect with each other. Again, we're trying to increase social network connections, right? These positive connections. And so it's just been amazing to me that we've been able to recruit and get people from all these different areas. So that brings me to kind of the last piece of my talk, which is, when we're developing all of these interventions, we really have to think outside the office. And probably for many of us the last year, maybe this was your office, right? I know this was kind of my office for some days, except, I happen to have a dog sitting there too. But, we really have to think about that. We can't develop something and then it doesn't work. And so we've got to think about, if we're going to do this, how are we going to create it so it works, so we get people to come? One very important thing that we've noticed, and probably those of you that do this work do, is that you have to identify people who are going to support you in your project. They need to be key community leaders. And for Makune and Takuna, these are people who have supported us in many ways, right? Talked to the community about our project, said, you know what, Dan and Liz have been doing this work, like Rand and UCLA are okay, like they come back to the communities and present. And what we've also been able to do is share our data. So Dr. Carrie Johnson, who heads our community partner center, it's called Sacred Path Indigenous Wellness Center. She's been able to take our data, she took it, helped her write a grant, and she got $500,000 to continue implementing Makune in LA. So awesome, right? Again, using what we got from our data to help others continue to implement it in the community. The other thing we have to get really good at is getting the word out. We need to not only publish in peer-reviewed articles, we have to tell people, lay people, what's going on? Like, how do you talk to teens about weed? Like, here's some things we found. And you've got to be able to get it out there so people see it, read about it, hear about it. So we've been very good at being able to get information out there to help people think about these issues at the lay level. We also need to talk to policymakers, because if we want things to change, we want to see things happen in communities, we've got to talk to them too. So we brief a lot of Senate and House committees on our work. Our work that Dr. Dunbar did on vaping was one of the few things cited by the FDA commissioner, talking about the importance of how teens who start vaping, it's not harm reduction, 50% go on to combustible cigarettes within a year. And then, as I mentioned earlier, we've been able to use our data to inform state legislature and get ordinances around advertising for marijuana. So these are important ways that we can use our research that I think we don't always do to make changes, both in communities and policy. We also, to bridge the gap, we have to make our interventions accessible. So one of the things that I've worked really hard at is to put our stuff out there so people can have it for free. So we have a whole website here called groupmyforteens.org that we developed that is free. It has all of our curricula, Choice, Free Talk, and Makune up there, our Group MI. You can download the curricula for free. You can watch the training videos for free. You can have everything for free, and it helps people implement it. So right now, Choice is getting implemented across the US in different school districts. I have people call me and I help them figure it out. Free Talk is getting also implemented in different places, and not just teen court, it's for at-risk teens. So sometimes even in schools, they'll implement it with teens maybe who get in trouble with an alcohol or drug offense. And then, as I mentioned, Makune is currently getting implemented with Sacred Path Indigenous Wellness Center in LA County. So the other thing we have to do is, so we want people to do our interventions, but maybe they don't have the training. So I worked with NIDA Clinical Trials to develop this program that is free, continuing education, called Engaging Adolescent Patients About Marijuana Use. And it is based on the digital recordings of that chat intervention I told you about, where real facilitators and real teens doing motivational interviewing, talking to each other, real things that teens said. And we created this program where you can come in and talk to David, who has different levels of marijuana use, depending which David you get. And when you talk to David, depending how you talk to him, determines what he tells you. So if you tell him, you better stop using pot, then he pretty much shuts down and your session's over. Right? So you can ask him questions, you can see other things, and you get a score on your motivational interviewing. So this can be used for training. It's getting used in a lot of, for residents, it's getting used at UCLA and other universities to try to help people and providers learn how to better engage teens in this setting. And then another thing that we've been doing with our Takuna project is, for every publication that we have, we create this beautiful one-page document that tells the results in lay language and then leads people to our website if they want to learn more. And we disseminate it through listservs, we print it out, we send it to all the organizations in different places across the US so they can have access to this information. So these are all different ways that we've been able to do this. So as you probably saw from this talk, there's a lot of different settings that we have to work in if we're going to reach diverse populations. And so I think it's really important to keep thinking outside the box, and where do we have to go to do what we need to do. I think we've come a long way, I'd say, in the last 10 years, with people really doing more collaborative, really community-based work versus, I have this intervention here, I'm going to help you. Now it's more about, what do you need? What do you want? And so it's been exciting to me to see the field move forward in this way. I think we still have a long way to go. I think there's a lot we need to do about addressing disparities that still hasn't been done, particularly with sexual gender minority individuals, and really understanding what those disparities are and the types of interventions that might help them, different contexts, how we need to address it. But I feel pretty good about where we are, and I'm really excited actually to be able to be part of this and be, you know, like just thinking about our projects, Maureen, that we have with the NIDA Heal, just all the cool things that people are doing and working with different organizations is amazing to do this prevention work. So I feel like NIH has figured out that we need to fund more community engaged research. In fact, there's a call about that, and for health equity. So I'm like, yay, people, you know, they want to see this type of work. So I think that's exciting for all of us who do this. So that is all I have. I think I did pretty good on my time, and I'm happy to answer any questions that people have. I don't know how to look on the, here, let's see if I can hit escape to see the. Do we stop sharing, or I don't even know. I'm not going to touch it because I'll break it. Yeah.
That's a question. So
You have to use the microphone.
sorry.
I turned it on.
Oh, perfect. Thank you. So thanks so much. That was just really fabulous. You covered so much ground in that talk. One thing that I was wondering about was, as you shifted, you talked about sort of, yeah, everyone dealt with COVID and like the shifts that made to research plans. And with the Takuna project, I was curious, as you shifted to virtual, I guess two things. One, were there lessons learned of things that you'll continue to do going forward even if sort of going back in person into the community is possible, when and if that is the case? And also, were there changes you had to make to the intervention as you decided to go national? Sort of, you talk about like content that might be like sort of like pan Native American as opposed to content in the intervention that might have been more specific to specific tribes local to California.
Oh, right. Yeah, so that's a good question, because what's important to understand with urban communities is that there are so many tribes represented. And so for us from the very beginning, even with Makune, we did not make it really tribally specific. And that was based on talking with the community. So it was very pan-Indian in terms of, and also because people were coming in where they didn't even know their tribe, knew nothing. And then we might have people come in who were a powwow dancer. And so you wanted to make it feel comfortable for everyone, no matter where they were at with their cultural level. And so same for Takuna, we kind of created, and then people could talk about, like, when we do the, when we do the cooking, they could talk about specific recipes maybe that their tribe did, because we kind of tried to pick something that many people like Three Sisters do, but they might create it differently. And so in that way, and then regarding the virtual piece, I have to say, there's no way we could go back in person at this point, but what's been frustrating is, the pandemic's over. And so people don't want to be on Zoom. And so we've had trouble in the last few months with attendance. And so we're thinking, maybe we need to like just shorten our intervention and make it an hour. Maybe we need to figure out, okay, half hour MI, half hour, cooking, because we need to keep, we have about 100 more people to go. And I'm like, if we keep it this way, I don't know. And I feel like, you have to be fluid. And, my statistician isn't pleased with me, but I was like, Anthony, if I wanted to do this and tell my stories, talk about what could we do so we could maybe make it work? Because we can keep doing it this way and no one comes. And then what's the point of that? If only 65% of the people are getting any workshops, then you have a whole group who's getting nothing. So now you've created a whole nother group. So now we have 3 groups. Right. And so, I think it's hard when we deal with these huge kind of issues like this. So we're still figuring out what to do.
Hi, thank you for your presentation. I learned a lot too. I was wondering if you could expand a little bit more about the development of the medicine wheel that was used in Makune and I think Takuna. There was something very similar. Is it based off of like a common model when addressing Native American groups, or is it something like unique to your project?
That's a really good question. So the medicine wheel is so different for different tribes. And so when we talked with the communities in both, they felt like it was important to ground it in that, and that we should talk about it generally and give people an opportunity maybe to talk about for their tribe how the medicine wheel is viewed. And so it's very fluid. So we talk about, there's a medicine wheel and there's 4 quadrants. What are the 4 quadrants, for your tribe, and so it gives people an opportunity to kind of discuss. It's very interactive, but we try to start with something. Same when we talk about the cooking or like the sage ceremony, right? People have different ways maybe that they use sage or how they use it. And we just try to open it up so people feel comfortable about sharing their experiences, while we also, and the facilitators are all Native American, but they also, try to teach a little bit about it too. So it's finding a balance, because what's interesting when I listen to the workshops is a lot of people maybe that are coming to this don't have all the experiences, and some do, and they can share it with their peers too. So it ends up being kind of cool because it's different people every time in the workshops because they rotate. So you just don't know what you're going to get. So you have to be ready as the facilitator to really kind of pull what people say and use it. But that's a really good question. I'm probably supposed to stand here where people on Zoom can see me. Sorry.
Ask a question, but I don't think I need the mic.
I can hear
Can
you.
you hear me?
Yeah.
Okay. So thank you for this awesome presentation.
Sure.
Just have one question here about maybe some key things that you've learned as you stood up your community advisory panel, as you engaged them in your work. Maybe some key, after action things that you've learned and strategies maybe for engagement?
Yeah, I mean, I think the most important thing is that they have to be involved from the very beginning. So you can't just develop something and then show people. They have to be involved from the beginning. Like you can have ideas, I mean, we know we need to address substance use, and we know that like talking about norms or social network works. But what do you think? And what does that look like? And so we end up changing like a lot of our handouts or how we talk about it. And even with Takuna, like a lot of the providers said, we use this social network. Like they said, we don't call it this, but we show people their connections and we find it very helpful. And so I think that, and then I also think we have to go back to the communities throughout the entire study. So like those handouts we do briefings, we talk to organizations, or I go back to the schools, I present to the district, I present to the teachers, really share the data. You don't come in and do stuff and leave. You go back and you say, let me show you what's going on with substance use and let me talk to you about it and let me help you think about it. And I think that's really important. And it takes time. But for me, it's worth it because I think, then it makes a higher likelihood that the community is going to do the project, another project, right? They understand the value of research also. And they feel like more committed, I think. Like, we're really glad we did this because, it helped us and we can see from the results.
Thank you.
Yeah, no, it's a good question. Okay, not a stat question now. Don't get tough on me.
Gotcha.
You were loud, it's okay.
Okay, so one of the studies you talked about earlier in the talk, and I really liked the talk, it was awesome, but one of the things you talked about was how you could change their norms about, or what their perceived norms about other people's substance use by just kind of telling them something different. I was wondering, would the ability for that to work, would that depend on the actual background rate of substance use in the school or in the community? Because what if there's a ton of substance use in the area? I mean, and you tell them that there's not, I mean, would you think it would work in that case? Or
That's such an excellent question. So, and that comes up like where it could backfire, like in teen court, right? Where you're like, well, guess what? So an important part of it is not to be like, nobody's drinking. It's not happening. So what we try to do is we try to give national statistics because that's exactly what they say. And we want them to say that. And they'll be like, oh, but at my school, everybody drinks. And so we say, okay, well, you know what? It might be a little higher at your school, but let's think about that for a minute. What do teens talk about after the weekend? Oh, Bobby was puking in the bushes, not like I ate popcorn with my parents, right? So then they're like, yeah, you know what? Like everybody does talk about drinking, but I know a lot of people who don't drink. And so we try to bring it up, but it's good you brought that up because that's exactly it. And they start paying attention maybe more to what's around them. And in some cases, there might be more substance use. And they might say, well, all my friends around me drink. And then you talk about, okay, well, do you have friends who don't drink? Well, yeah, I do. And you know what? Gosh, they don't do. And so it's just finding that way without making it feel like, no, nobody's doing it. So you got to it's using the MI really. But that's a really good point because that's exactly what they say. And it's hard to change norms, but we know that if you can, it can really change substance use too.
So I want to ask about, so Choice's after school program administered in school settings and project chat is, well, originally only administered in primary care settings. Did you find any barriers to the implementation in like a school setting versus
Yes.
a primary care setting?
I'm going to say they're both really hard. So I think that speaks to why you have to start talking with people early. It took me almost, and we got lucky because my grant got funded late for Choice. got funded in, I think, October, and which was a good thing because we couldn't start then our randomized control trial because it took me, even though I had people on board, it took a little bit to get LAUSD to get on board with some of the, some of the schools. And so, but I find like, and this is what I teach in my UCLA class, once you can talk to people and really explain to them, like, here's what I can give you and here's what I need from you, and you're getting this really cool free program. And if it works, it's going to address such an important problem. And in my 20 years, I've only had one person say, no, we don't want to do it. So I find like, and I try to email, I don't hear back. So I would just show up at the school. Hi, I'm Dr. D'Amico. I've been emailing you for like 3 weeks. I know you're super busy, but can I just have 5 minutes? And then it's really hard to turn me down when I'm right there. So, and that's what I tell my students who work in public health and they work in social work and all, if you're going to do this kind of work, you have to go out there and do it. And you have to really show the community why they should do it because they're busy. So don't tell me I'm going to have to collect consent forms for you and you give me nothing, right? When we had them collect consent forms for choice, I said, if you get over 90% of the consent forms, you get $3,000 for your PE department. We had the PE teachers. 85, 2,500, 80, 2,000, whether it's yes or no. Okay, you got to be careful about that. Whether it's yes or no, I just want the forms. Well, guess what? We had over 90% at every single school because we were paying them to do it and they should get paid to do it. They shouldn't just have to collect those. And so I think, we've got to put that into our grants, how to also reimburse the community appropriately if they're going to be participating in these projects. Can't just expect them, oh yeah, and I know your staff's really busy, but I have these 10 research tasks they need to do too. No, right? Nope, you got to hire someone to help them do it. And you got to put that into your grant. So I think those are really important things. So it's not easy, but I think it's thinking about incentivizing people in appropriate ways to be part of research and making it fit for them.
Great. Do you want to ask a question? Okay, I think this will maybe be our last
Oh
question.
no, make it
and then
really hard.
we'll
No.
wrap up.
The hardest question.
Thank you so much. That was an amazing presentation. I noticed that, so you had talked all about your projects that are focused on substance use prevention, cannabis, alcohol, opioids. I also happen to know that you do some work related to suicide prevention with Alaskan individuals. So I guess my question is, when the behavior that you're focusing on is different, do you feel like the approach you're taking with community partners still applies, or is there any unique factors that would maybe differ when you're focusing on suicide prevention versus substance use?
That's a really good question. I've learned a lot from this new PCORI project, working with Dr. Stacy Rasmus, who's been doing work in suicide prevention for over 20 years. And one of the things that her intervention is focused on, it's called Kinezovic, and we're building off of that to do a brief intervention, because right now what happens in Alaska is a youth, maybe suicidal, get flown in from the village, probably in handcuffs, taken to the hospital. By the time they get there, after 3 plane rides, they're like, I'm not suicidal, I don't want to deal with this. And then they might get flown back and they don't get anything. And so we're trying to provide something. But one thing I learned from working with her in the community is that you don't directly address it, suicide. You address how to be protective when you go back to your community, and you address it in a different way. So we had to really explain that, like, to the IRB, to other, like, we're not going to be like, are you suicidal? Why are you suicidal? We're not going to be talking about that. We're going to be talking about who can support you in choices when you get back home, which relates to that, and who can support you in your mental health. And so I think, in learning from the community in that way, and from her work, and it's educating our IRBs too. It's educating them, like, things are going to look different, right? And also educating them, like, the state of Alaska is like as big as half the United States. So, there's remote places. And I think that's a big part of what I do too, is really trying to get the IRB to understand what this needs to look like. And it might not look like we're still protecting participants' safety and we're still addressing the issue, but it has to be culturally and developmentally appropriate too. And this is what the community tells us. So, yeah.
Well, it is a few minutes after 5 So.
And there might be some meatballs left.
Right, there are really nice snacks outside, and so I'm sure we can continue the conversation more informally outside.
Yeah, I'm happy to chat. Thank you all if you were on Zoom. Thank you.